Hello, my name is Natasha Oyedele, and I will be discussing the public health perspective of alcohol and drug use. I will begin with a brief introduction to the addiction process and then discuss substance use, risk factors, and prevention, review the epidemiology of substance use, and finish by discussing substance use treatment. So when we think about alcohol and drug use, what are some substances that come to mind? Here is just a list of a few that may be familiar to you, including tobacco products, alcohol, cocaine, several prescription opioid products, as well as prescription stimulant products. Let's begin our discussion by reviewing the addiction cycle and outlining the process of addiction as illustrated in the figure. The brain adapts to the introduction of drugs. With repeated use, it compensates and continues to adapt. This adaptation is the addiction process. It's important to know that addiction is a process. There's no such thing as using a substance one time and being addicted. That's not possible, no matter what substance you're talking about. Some substances can be incredibly reinforcing, but there's still a process of your brain adapting to a particular drug that's being introduced and responding in kind. Related to the addiction process, tolerance means that there is a reduced effectiveness of a drug after repeated administrations. Over time, greater amounts are needed to produce a desired effect. An example of tolerance is a person who uses marijuana for the first time who may get very high and very silly after just a small amount. That same person, 6 months later, if they used every day, would need much more marijuana to get that same level of giddiness and silliness and get to the same level of being high. Withdrawal, also called a withdrawal syndrome, is a set of symptoms that occurs reliably when someone stops taking the drug. There are physiological and psychological symptoms. The severity of withdrawal ranges widely across different drugs. For example, marijuana has a very mild withdrawal syndrome, whereas opioids have a very severe withdrawal syndrome. The addiction process, or the cycle, begins with preoccupation and anticipation. This stage involves persistent desire and craving for the substance or an activity, with the individual often anticipating the pleasurable effects. Over time, the brain begins to adapt to repeated drug use. Following this, the individual may enter the binge and intoxication phase, where they consume larger quantities to experience the effects, reinforcing the cycle. When the person stops or reduces their substance intake, withdrawal symptoms occur. These symptoms reliably happen when someone stops using a particular substance and can be quite challenging, further driving the cycle. Finally, the cycle loops back to preoccupation and anticipation, often with persistent physical and psychological problems which reinforce continued drug use. The addiction process can be further contextualized and understood through the lens of behavioral conditioning. The first important concept is reinforcement, which means something increases the likelihood of a behavior in the future. Initially, substance use is driven by positive reinforcement. As tolerance develops and withdrawal symptoms emerge, negative reinforcement takes over. When a person uses a substance and experiences pleasurable effects, that positive reinforcement acts as a favorable outcome, a reward that increases the likelihood of repeating the behavior. Essentially, the brain associates the substance with feelings of pleasure, strengthening the behavior. For example, a little pep after an afternoon cup of coffee. This is an enjoyable effect of substance use. Avoiding the negative effects of abstinence or discontinued use is the negative reinforcement. In the context of substance use, after repeated use, the behavior can stop or reduce the aversive stimuli or feelings, such as withdrawal symptoms or negative emotional states. This means the individual continues substance use not just for pleasure, but also to avoid discomfort and negative feelings. An example is the buzzing that stops when you click your seatbelt, or snoozing on an alarm clock to stop the averse stimulus of the annoying sound. Substance use, and another example is substance use to remove the symptoms of withdrawal. Together, the reinforcement process, both positive and negative, play a central role in the development and persistence of substance use disorder. They explain how behaviors become ingrained and maintained over time, making addiction a learned behavior reinforced by reward and relief from negative states. When we think about substance use disorders, it's helpful to talk about risk factors associated with substance use disorders. Generally, the more risk factors a person has, such as early life trauma, chronic stress, a family history of addiction, or peers who use drugs, the greater the chances that they will use substances or develop a substance use disorder. Even in the presence of multiple risk factors, substance use and substance use disorder are not inevitable. Other factors can help protect someone using substances and developing a substance use disorder. Protective factors, including individual traits like optimism and environmental influences like a healthy family environment, peer relationships, or financial stability, are examples of protective factors. It's important to note that many risk and protective factors are not a result of choices an individual person makes, but rather a facet of inherited genetics, family life circumstances, and other aspects of their biology and environment. While many people try and use drugs at some point in their lives, only a subset of individuals develop substance use disorders. Interestingly, no single factor alone determines whether someone will develop a substance use disorder. Instead, it results from a complex interplay of various individual and societal factors. Here are a list of a few at the individual level, the family level, the community level, and the structural level. When we think about an individual risk factor, an example is the age of first use of a substance or age of substance use initiation. Drug use at a young age can influence brain development and behavior in ways that increase the likelihood of going on to use other drugs and developing a substance use disorder. People who start to use substances as children and young adolescents are more likely to develop a substance use disorder than those who use substances in late adolescence or young adulthood. For this reason, most prevention programs focus on preventing or delaying substance use during this time period. At the family level, a family risk factor may be parental substance use and attitudes. Whether parents use drugs or alcohol, and their level of acceptance of substance use can influence whether a child or adolescent is likely to use substances. At the community and neighborhood level, studies show that aspects of a school environment, such as how often other students use drugs and how connected students feel to their classmates, can influence whether students use or avoid substances in youth. At the structural level, stigma and discrimination can cause chronic stress that makes someone more vulnerable to substance use and to developing substance use disorders. This slide illustrates the continuum of prevention and harm reduction efforts. At the core, prevention aims to reduce the initial onset of substance use or delay or prevent progression to more substance use, to more severe use. On the left side, you see that we start with primary prevention, which is the most protective level and focuses on preventing the initiation of substance use altogether. It targets the general population and aims to promote healthy behaviors before any use occurs. Secondary prevention targets individuals showing early signs of substance use or those at higher risk. The goal here is to intervene early to prevent escalation to more problematic use. Tertiary prevention focuses on individuals who already have a substance use disorder, and the aim is to reduce harm, improve health outcomes, and support recovery. So now we'll talk about a few of these alcohol and substance use products that we showed on one of the early introduction slides. And when we think about alcohol use patterns, it's important to explore different patterns of alcohol use and their potential consequences. This diagram illustrates the spectrum of alcohol consumption, ranging from no use to heavy use and dependence. Starting at the bottom, the absence of use indicates individuals who do not consume alcohol at all. Moving upward, we see low-risk use, which involves moderate drinking without significant health or social problems. As consumption increases, we enter the unhealthy use zone, characterized by risky drinking behaviors that can lead to harm. This includes problem drinking, risky use, which may not yet constitute dependence, but pose health risks. At the top of the triangle, we see heavy alcohol use and alcohol dependence. Heavy use can lead to alcohol-related disorders and dependence, and is marked by strong cravings, a loss of control, and withdrawal symptoms. The vertical axis indicate that as alcohol use increases, so do the potential health consequences and social consequences and risk for addiction. So this slide just has an overview of some of the substance use facts and its impact. And first, alcohol use related deaths are a significant issue, with approximately 88,000 deaths annually in the United States from 2006 through 2010. The cost of excessive alcohol use is also substantial. In 2010, it's estimated that approximately $250 billion were the cost of excessive alcohol use in that year, and that's attributable to lost productivity in the workplace, medical expenditures, criminal justice costs, and motor vehicle collisions. When we think about a standard drink, 12 ounces of beer is approximately 8 ounces of alcohol, whereas a 5-ounce glass of wine is about 12% of alcohol. And understanding these facts helps us to recognize how much alcohol is consumed in different beverages. Underage drinking remains risky, and in 2016, about 20% of 12 to 20-year-olds reported alcohol use, and about 12% of those same individuals in that age group were heavy drinkers, which accounts for about 7 million young people. By age 21 or older, there were about almost 56% of adults who reported alcohol use, and about 6% of those in the 12 to 20-year-old group reported heavy drinking. And the older age group, that was about 6.5%. There are different terms that describe drinking patterns for alcohol consumption, and these terms are useful in research and help people to evaluate and make informed decisions about their own drinking patterns. And when we think about alcohol, excessive alcohol use, that includes binge drinking and heavy drinking and increases the risk for alcohol use disorder. So binge drinking is defined as consuming alcohol in one occasion, having 4 or more drinks if you're a woman, and 5 or more drinks on one occasion for men. Heavy drinking, on the other hand, refers to a consistently consuming large amounts of alcohol and amounts to about 8 or more drinks per week for women and 15 or more drinks per week for men. The association between alcohol and cancer is an important topic to also discuss, and that association was identified in 1987. And there's strong scientific consensus on the association of this alcohol drinking relationship with several types of cancers. Research shows that alcohol is causally linked to different cancers of the mouth, the oral cavity, the esophagus, the larynx, the liver, colorectal, and the female breast. The more alcohol a person drinks, the higher the risk of cancer. And there is no safe limit of alcohol use in terms of cancer risk. On the map, we see that alcohol is responsible for approximately 3.5% of all cancer deaths in the United States, and specifically accounts for 3.3% of female cancer deaths in Europe. Additionally, studies indicate that between 25 and 35% of cancer cases in the U.S. are attributable to alcohol consumption, particularly among those who drink less than 20 grams per day, which is roughly 1.4 standard drinks. We'll now transition to talking about tobacco use and its health effects. Tobacco use is the leading cause of preventable disease and death in the United States, and the figure here is from the Surgeon General's report showing the health consequences that have been causally linked to smoking. Cigarette smoking has been causally linked to nearly every organ in the body, to diminish health status, and to harm the fetus. The prevalence of cigarette smoking overall has declined among adults in the United States. The problems from smoking have declined from about 20% in 2005 to about 15% in 2015, but that still represents about 36 million adults. And although the overall prevalence of smoking has declined in the U.S., tobacco cigarette use remains high among certain populations. We see higher prevalence of cigarette smoking among individuals who live in southern and Midwestern regions of the United States, individuals with low educational attainment, and those who live below the poverty level. An important aspect of tobacco epidemiology is our tobacco flavored products and tobacco control. And the 2009 Family Smoking Prevention and Tobacco Control Act was legislation that was put forth to ban cigarette flavorings in tobacco cigarette products. It was a significant step forward in tobacco regulation, and it banned most cigarette flavorings, including cherry, chocolate, and other sweet flavors that typically appeal to youth. However, menthol was exempted from this ban, which remains a point of concern because menthol-flavored cigarettes are particularly attractive to younger smokers, a younger population, and Black and African American populations. And in this figure, we see that both Black men and women report a much greater percentage of menthol use cigarettes. Those are smokers aged 12 and older, compared to other racial and ethnic groups. Another thing to note is that the 2009 Family Smoking Prevention and Tobacco Control Act did not extend to non-cigarette tobacco products. This means products such as cigarillos, chewing tobacco, e-cigarettes, and other non-cigarette tobacco products are still sold in flavors such as strawberry, cotton candy, bubblegum, chocolate, and many others. There are several tobacco control strategies that have been effective in reducing tobacco use, which include cessation programs, package warning labels, mass media campaigns, and advertising bans. For the purpose of this presentation, I will only briefly talk about package warning labels. So in this same legislation, the Family Smoking Prevention and Tobacco Control Act, it also mandated that by September 2012, cigarette packs and ads must have larger and more visible graphic health warnings as part of an effort to educate the public about health risks associated with smoking. Here are some examples of cigarette package warning labels that have been suggested. In contrast, we see the Arriva non-cigarette tobacco product the green labeled product with white lettering that doesn't include the same graphic health warning, because unfortunately the same graphic health warnings that had been mandated for cigarette packs was not implemented similarly for non-cigarette tobacco products. We'll now transition to talk about prescription opioid products and opioid use more broadly. Opioids are a class of drugs that can relieve pain, cause relaxation, and produce a feeling of euphoria. They interact with opiate receptors on nerve cells in the body and in the brain. The National Survey on Drug Use and Health in 2023 tells us that about 8.9 million people over the age of 12 misused opioids in the last year. And this accounts for either using illicit opioids or using prescription opioids in a manner that was not prescribed. It's also important to note that opioid use does not occur in a vacuum, absent of other substances. Polysubstance use is a common occurrence, whether it's purposeful, using multiple substances simultaneously, or unknowingly using a substance contaminated with another drug. Fentanyl, in particular, is important to consider when discussing polysubstance use. It is highly potent and lethal compared to other opioids. In recent years, we have seen that the heroin supply has been adulterated with fentanyl, which has led to high increases in overdose deaths. We've also seen fentanyl entering cocaine and methamphetamine supplies in recent years. When understanding the opioid overdose crisis, it's important to not just think of all opioids as interchangeable. This graph shows us that opioid overdose deaths can be broken down into categories of commonly prescribed opioid products. First is the teal color, which are the commonly prescribed opioids, include natural and semi-synthetic opioids and methadone. The blue line represents heroin. The purple line represents other synthetic opioids, including fentanyl and tramadol. And the black line represents the sum of all of these products. And when we think about the opioid epidemic, it's commonly thought about in three waves. Wave 1 is the rise in prescription opioid deaths, which started in the 1990s and involved prescription opioids, both natural and semi-synthetic, increasing during this time to manage pain via the prescribing of oxycodone and hydrocodone. Wave 2 was the rise in overdose deaths, which started in about 2010. And this rapid rise in overdose deaths involved heroin, which may have resulted in the tightened regulations in prescription opioid products and having heroin be more accessible for those who may have switched to use this product at this time. Wave 3 was the surge in synthetic opioids, particularly fentanyl, that began around 2013. And that was at the time where there were substantial increases in opioid overdose deaths involving synthetic opioids and involving illegally made fentanyl and fentanyl analogs. This image is another rendering of the CDC graph, but with an added fourth wave that has been discussed in the research. So this emerging fourth wave that we see represented by the red band on the x-axis is the polysubstance use and drug poisoning wave that started around 2018-2019. And this was characterized by an increasing combination of opioids with other substances like methamphetamine and cocaine, leading to complex overdose scenarios. And this wave represents how the epidemic continues to evolve with overlapping drug use patterns, amplifying the risk of fatal overdoses. When we think about the use of all types of substance use products, opioids, think about tobacco use as well as alcohol use, routes of administration is important to consider in terms of the ways that people consume drugs. This could include oral routes, such as swallowing, application to a mucous membrane or skin, inhalation or injection. And basic examples of oral or swallowing are via pills or alcohol. And this is because it goes through the stomach and has very slow absorption. When we think about application to mucous membranes or the skin, there are a couple of subcategories with this route of administration. There is an option for putting a particular substance under your tongue, sniffing or snorting, such as powdered cocaine, or rectal administration or transdermal administration. And most of these aren't used with drugs of abuse, with the exception of sniffing and snorting, which is common for powdered cocaine. When we think about inhalation, that's smoke or vapor entering your lungs and then into your bloodstream. Inhalation has two modes. There's smoking, specifically smoking combusted material through cigarettes or a joint, or vaporizing, where you heat a liquid or material and a vapor emerges and that vapor is inhaled. Injection is the route of administration that has the most rapid absorption and requires a needle and syringe. Injection is an important route of administration for several reasons. First, it can cause infections, so injection drug use is why there is a strong link between substance use and HIV or hepatitis C. Injection drug use can be subcutaneous, under the skin, in the muscle, or in the vein. All of these modes of injection are associated with a vulnerability for infection. And the graph on the bottom is just an illustration of how drug concentrations in the blood vary over time with these different routes. When we think about opioid use disorder treatment, there are three evidence-based treatments for medication for opioid use disorder, or MOUD. Methadone, there's buprenorphine, and extended release naltrexone that are currently approved by the FDA for treatment of opioid use disorders. Methadone and buprenorphine are opioid and agonist treatments that activate the brain's opioid receptors and in the same mechanism as prescription or illicit opioids, but in a safer manner with less euphoria. Methadone is typically taken orally once a day. By law in the U.S., outpatient methadone treatment can only be administered by people enrolled in certified opioid treatment programs, historically called methadone clinics. In addition, patients on methadone are often required to attend regular counseling sessions with clinic providers. Buprenorphine is typically taken under the tongue. In the U.S., buprenorphine can be provided by an opioid treatment program, but it's more commonly prescribed in an office-based setting. In order to treat opioid use disorder with buprenorphine, prescribers in the U.S. must undergo training and obtain a waiver from the U.S. Drug Enforcement Administration. Only a limited number of providers pursue these waivers. About 2 to 3% of physicians in the U.S. are waivered to provide buprenorphine, and most of whom are in urban areas. In 2017, nurse practitioners and physician's assistants became eligible to apply for training to obtain waivers. Naltrexone, an opioid antagonist, works by blocking the opioid receptor and eliminating the euphoric and pain-relieving effects of opioids. It can be administered by mouth daily or as an injection once a month. Despite these effective options, only about 20% of individuals with opioid use disorder received treatment in the past year, with even fewer on evidence-based medications. There are several reasons for this low percentage of treatment usage. One being public stigma. That's the society's negative attitudes towards treatment seeking. Provider stigma, which is healthcare providers who may have a bias against prescribing medications for opioid use disorder, and their regulatory restrictions, which include the methadone's requirement for a specialized clinic or the waiver needed for buprenorphine use. Here we see the percentage of outpatient substance use treatment facilities that offer medication treatment. You can see from the top green line that less than 40% of substance use treatment facilities offer any kind of medication to treat opioid use disorders. The second line, we see yellow, which represents buprenorphine, and that's less than 20% of facilities offer buprenorphine. We see less than 15% offer naltrexone. And finally, we see at the bottom line, the red line, we see less than 10% of substance use treatment facilities offer methadone. And it's important to note that even fewer number of facilities offered all three types of medication. Most facilities that offered at least one type of medication did not offer multiple types of medication. As public health scholars and future public health researchers and professionals, it's important to use language that is scientifically accurate and that is person first and non-stigmatizing. I encourage you to say things like a person with a substance use disorder rather than abuser, addict, or alcoholic. When we think about stigma specific to substance use, it stems from an antiquated and inaccurate belief that addiction is a moral failing, instead of what we know to be a chronic, treatable disease for which a person can recover and lead a healthy life. It can reduce a person's willingness to seek treatment and can negatively influence a provider's perception of people with substance use disorder, which can impact care. This slide is an extension of using person-first language and thinking about the opioid use disorder treatment and the use of medications for opioid use disorder rather than medication-assisted treatment, or MAT. There's a misconception that medications for opioid use disorder merely substitute one drug for another or one addiction for another. The term MAT implies that medication should have a supplemental or a temporary role in treatment. Using the term medication for opioid use disorder aligns with the way that psychiatric medications are understood as critical tools and central to a patient's treatment plan. There are other medications that are used for individuals who have substance use disorders or alcohol use disorders. One is an overdose reversal drug called naloxone or Narcan. What Narcan does is rapidly reverse an opioid overdose, preventing fatalities. The drug itself is an opioid antagonist. What that means is that it binds to the opioid receptor and can reverse and block the effects of other opioids. It can very quickly restore normal respiration to a person whose breathing has slowed or stopped as a result of overdosing on an opioid. We haven't yet talked about the effects of opioids, but one thing that it does is cause respiratory depression. In large amounts, it can be fatal. Naloxone is an important tool to prevent opioid overdose deaths. Another medication is Antabuse or disulfiram. What this drug does is cause unpleasant reaction when alcohol is consumed. Someone who is using Antabuse if they consume alcohol, they will have an adverse reaction. This is actually an example of punishment if we think back to our discussion on behavioral conditioning. Antabuse is used in recovery programs that include medical supervision and counseling. Thank you.